Hi everyone, Dr.Jyotsna here. Let's talk about bradycardia and AV block. Bradycardia is heart rate less than 60 and it becomes symptomatic generally only when it is less than 50. And we will get sign and symptoms of hypoperfusion like ultrasensorium, chest pains, hypotension, ये sign and symptoms of heart failure. Sinus bradycardia means P wave will be present and the heart rate will be less than 50. And PR will be at normal interval. PR will be point 0.12 to 0.2 second. AV block, first degree AV block is basically P wave will be followed by QRS complex, but the PR interval will be greater than 0.2 second, that is greater than 5 small box. Second degree AV block is of four type: Mobis type 1, Mobis type 2, 2:1, or higher degree block. Mobis type 1 is is also called Wanky back. In this, there is a cyclic prolongation of PR interval and sudden drop of P wave conduction. In Mobis type 2, the PR interval will be constant, but there will be sudden drops of there will be sudden drops of P waves. So here you can see this PR interval. These PR interval are constant, but some P waves, this P wave, and these two P waves are not getting conducted. This and this P wave is not getting conducted. So there are sudden drops of P wave, but the PR interval is at constant interval. So Mobis type 2, type 1 is generally at AV node. The problem is at AV node, and type 2 the problem is below AV node. So once it is below AV node, generally it will be broad complex QRS, and if it is at AV node, it is a narrow complex QRS. Third degree AV block is a basically complete heart block in which artery contracts on its own and ventricle contracts on own rhythm. So P wave PP interval will be equal and RR interval will be equal. This type of rhythm generally causes cardiovascular compromise and death may occur. Thus, immediate recognition and pacing will be required. What is the management? Basically, any bradycardia, if it is symptomatic, needs attention, immediate attention. We have to rule out any beta blocker, calcium channel blocker, or digoxin, or any AV node blocking agent if the patient is using or not. We have to rule out any toxicity. Dyslipidemia, generally hyperkalemia, causes bradycardia. Myocardial ischemia or infarction, especially inferior wall MI, RCA block will cause infarction. It will cause bradycardia. Myocarditis, hypoxia can cause bradycardia. Morbus type 2 or third degree AV block, even if it is asymptomatic, will need permanent pacing. Generally, the immediate management is look for airway, breathing, and circulation. Give a drop-in. Drop-in is the first drug of choice. Uh, 1 mg per 1 mg IV stat. You can give maximum of 3 mg. Now, if it is not effective, start on put transcutaneous spacing or give chronotropic agent like dopamine or epinephrine. Take expert opinion. Rule out the causes. Put transvenous spacing.